First of all, I would thank the Lung Academy to give me a role to speak on the role of intervention radiology in management of bone metastasis. So these are the brief headings in which I would be describing. So as Dr. Ashish told, 30 to 40% of the patient in lung cancer develop bone metastasis, and these can be either osteolytic, osteogenic, or mixed, and the spine being the most common site of involvement, followed by ribs, ilium, sacrum, and of which the thoracic vertebra is the most common site of involvement. So with now improved surgical techniques, availability of chemo and radiotherapy as well as immunotherapy, the survival of these patients with metastasis has prolonged in carcinoma of lung. So coming on to the mechanism of bone metastasis weaken the structural integrity via osteoblastic and osteoclastic activity, which leads to collapse of vertebral body or any bone in the body, and this leads to vertebral compression, fracture, or for that matter, compression of the pelvic bones. And 30% of bone metastasis will have vertebral compression fracture. So the goal in intervention radiology is first to preserve and restore the neurological function, to improve the pain control, to have improved quality of life, and to maintain the spine stability or acetabular stability as well. So role of intervention radiologist in bony lesion. So first and foremost is diagnosis, that is biopsy, image guided percutaneous biopsy, either just aspiration or percutaneous biopsy. And coming on to the management of bony lesions in vertebra, it would be for pain palliation and stabilization for in the form of vertebroplasty, kyphoplasty, that is balloon insertion, and followed by cementoplasty. You can combine with ablative therapy like radiofrequency, microwave, or cryoablation along with cementoplasty. And in any other part of the body, it is called as osteoplasty or acetabuloplasty in acetabulum. Coming on to the image guided bone biopsy, this is a safe, effective, accurate diagnostic tool as compared to open techniques. And the indication in which the biopsy is performed first is to confirm the histological characterization of the focal bony lesion, as Dr. Gulia has already told. And the receptor and immunohistochemical analysis, with the advent of newer molecular therapies coming in, the receptor and immunohistochemistry is the most important thing. And to characterize the fracture, that is to differentiate between osteoporotic metastasis versus versus a metastatic disease or inflammatory origin. We can do either with the help of CT scan guidance if it is a focal lesion, under CT scan guidance. If it is if there is a large soft tissue along with the bony lesion, it can be done under ultrasound guidance. And if whole of the vertebral body is involved, it can be done with a fluoroscopy guidance. The advantage of fluoroscopy is basically it is much quicker as compared to the CT guided biopsy. So another, you can combine fluoroscopy with CT guided biopsy when we are performing C1, C2 biopsy, because it gives a real time image as well as we can do on the same table. So now let's come on to the some of the spinal lesions. So management of spinal metastasis. The treatment of spinal metastasis is complex, and it has to be done with multidisciplinary approach. And decision of spinal metastasis depends upon NOMS assessment, that is neurological assessment, oncological assessment, mechanical assessment, systemic assessment. So neurological assessment is by two methods. One is clinical and another is radiographic. In clinical, we need to assess the myelopathy and functional radiculopathy, so that the soft tissue involving the cord on the epidural spinal compression needs to be addressed. If it is if the soft tissue is less than 1/3 involvement of the epidural space, then vertebroplasty can be easily performed. If it is more than 1/3 and compressing the spinal cord and canal, and that becomes contraindication for doing vertebroplasty, and that is an indication for urgent spinal decompression. So we can combine two techniques like ablation with cementoplasty when there is a soft tissue involving more than one third the soft tissue, but less than two-third, and the spinal cord is not involved. Combining heat-based ablation therapy like radiofrequency ablation or microwave ablation, where electromagnetic waves are used, can combine with cryoablation where the ice formation is there, and laser ablation and HIFU, which is recently come up. So there are various types of pain which are there. One, we need to assess regarding the pain, whether it is a radicular pain versus an axial pain. If it is due to the pressure symptoms and it is involving the nerve roots, the management would be radiation, chemotherapy, and steroids. So steroids can be either per oral or intra lesional or intraarticular. So this was a patient where the patient had a focal lesion and patient had significant pain, and this is how the CT guided approach we had used for injecting steroids, and thus patient is relieved of pain. Another type of pain is due to compressive fracture or spinal instability. So where the management is either open surgery or percutaneous augmentation. So open surgery is morbid, and percutaneous ablation is the daycare procedure. Coming on to the pain score, the pain score is generally evaluated with visual analog score, visual analog scale of 0 to 10, where 1 being no pain and 10 being excruciating pain, which needs to be assessed. Another feature which needs to be assessed is oncological assessment, that is histology, sensitivity of radiation therapy, subtype of CA lung, whether it is a palliative intent or a curative intent. Mechanical assessment needs to be done with spinal instability neoplastic score, where one needs to address location of the lesion, pain, bony lesion, radiographic spinal alignment, vertebral collapse, and posterolateral elements of the spine. And the score which we get needs to be addressed. So when it is intermediate, that is 7 to 12, that is the time when we perform vertebroplasty. And if it is unstable, that is the time when it goes for urgent spinal decompression. Another thing which needs to assess in NOMS is a systemic assessment, that is a patient comorbidity, overall disease burden, and ability to withstand the procedure, and patient needs to continue systemic therapy and other procedures. So coming on to the indication of percutaneous augmentation, that is a combination either with only vertebroplasty or vertebroplasty with kyphoplasty. The indication is for painful vertebra as due to extensive osteolysis due to malignant infiltration by metastasis or multiple myeloma or lymphoma. Stabilization of vertebra, as in case of METs and myeloma, we can do combination therapy, that is ablation along with vertebroplasty when there is a soft tissue which is present, so that there's uniform distribution of the cement which is present. And the compression fracture is defined as less than 20% decrease in the vertebral height or more than 4 millimeter decrease in the vertebral height. So percutaneous augmentation can be performed either with vertebroplasty or kyphoplasty. So the main aim here is to consolidate the fracture, to increase the height of the vertebra, and for pain palliation. Coming on to the contraindication, so there are certain contraindication like bleeding disorder when there is retropulsion of the fracture fragments. Here there is more than 70% reduction in the vertebral body height, and when there is ongoing systemic infection or patient is allergic to cement, that is a time when these are contraindication. When the patient had a significant spinal canal stenosis or arthropathy along the spine, those are relative contraindication. Or when there is tumor extension into the vertebral canal or there is a cord compression. So these are relative compression. So let's go on to discuss a few of the cases. So this was a case of CA lung with vertebral metastasis. a metastasis at D6 and D8 level, where the patient had a pain score of 7 by 10 and was on two opioid medication. The MRI reveals D6 and D8 vertebral collapse. However, the cord signal changes were not present. Since the patient had significant amount of pain, vertebroplasty was done at two levels, where we see post cement injection, there is good distribution of the cement, and it also fills the crevices of the cement. And post that, the post procedure patient had a pain score of 2 by 10, and patient is off opioid analgesic, which is a great thing for the patient. When do we use a combination therapy? So this is a case of CA lung with a wedge compression fracture at a L3 vertebra. What we see here is a soft tissue along with the lytic vertebral lesion. There is decrease in the height of the vertebra, and bipedicular approach is taken, followed by ablation of this soft tissue, and after ablation we injected a cement, and the injection of cement is uniform and distribution is uniform. The pain, which was 6 by 10, reduced to 2 by 10 post procedure. This is another patient where we had performed for pain reduction, as well as there is a soft tissue. So the RF ablation was performed along with cementoplasty, and the pain score, which was 7 by 10, reduced to 3 by 10. So coming on to the response assessment, the pain relief in malignant fracture occurs in around 60 to 85%, whereas in acute osteoporotic fracture, the response assessment after vertebroplasty is around 90%. So there are certain, coming on to the review of literature, there are certain literature like this is a randomized control trial which studied at safety and efficacy of vertebral augmentation with non-surgical techniques, and here they use Ronald Morrison disability questionnaire, where at 1 month interval there was significant decrease, which was statistically significant as compared to the control group. And this study suggested that vertebral augmentation is safe and effective, and this was published in Lancet Oncology. This was another large prospective study of 128 patients with spinal malignancy, and out of which 87 were for spinal metastasis. So visual analog score decreased from 7.5 to 4.7 and after percutaneous vertebroplasty, and this was statistically significant, and thus it improves this. This is one of the meta-analysis of 180 articles where 7 studies were included, and vertebral augmentation was compared with other alone, as well as with other adjacent features like chemotherapy, steroid injection, and where vertebroplasty was done, the pain severity reduced to 0 from 5.1. So thus, in all the studies, it has been shown that there is significant decrease in the pain score. When vertebroplasty was compared with kyphoplasty, so there was no significant increase advantage of kyphoplasty, because the pain reduction, height recovery, and post-operative complications were same as with vertebroplasty. However, the cost of kyphoplasty was 2.5 times more than the vertebroplasty. However, kyphoplasty can be used in severe kyphotic angle and when there are multiple wedge fractures. When do we combine with radiofrequency ablation? So what additional advantage do we have? It destroys the tumor, that is one. It thromboses the paravertebral and intervertebral venous plexuses, and thus it minimizes the cement leakage. Cement is more uniformly distributed along the vertebral body, and the chances of cement into the canal is very, very less as compared to just vertebroplasty. And the pain score decreases from 8.6 to 2.6, and thus it is said that RFA combined with vertebroplasty is safe and effective. So another procedure that can be performed is sacroplasty when the patient is having carcinoma of lung and spinal metastasis. Patient has already been irradiated and now has developed a sacral insufficiency fracture. That is a time when a sacroplasty can be performed, and this is how sacroplasty was performed along the bipedicular, and cement was injected into the S1 vertebral body and along the insufficiency fractures. And the post procedure patient had reduction of pain from 8 by 10 to 3 by 10. Coming on to the acetabuloplasty, so here the indication of acetabuloplasty is generally to when the patient is having bone metastasis along with soft tissue which is present. And this was a 43-year-old female diagnosed with CA lung and had bone and liver lesion. A patient developed limping of gait and was walking with support. A patient had a pain score of 9 by 10 and MSTS of around 10 by 30. And here on CT scan, there was a lytic lesion in the supraacetabular region, and patient had a limping of gait and imbalance. So here we had performed RF ablation along with cementoplasty and creation of neoacetabulum. And thus, after acetabuloplasty, the pain score reduced to 3 by 10, which was 7 by 10, and MSTS improved to 24 by 30. And thus, there is good distribution of the cement along the acetabular roof. This is another patient where patient had metastatic disease along the acetabulum. RFA along with acetabuloplasty was performed, and pain score reduced from 9 by 10 to 3 by 10, which with just cement injection. Coming on to the review of literature, this is a meta-analysis of 30 articles which reviewed at 652 patients and 761 lesions of the size 4.5, where the maximum patients were of pelvis and another was a long bone. Cementoplasty was done in 60% of the cases, while rest was combination therapy like ablation with cementoplasty or implant with cementoplasty, and the pain reduction ranges from 3 which was 3.2 to 9.5, reduced to 0.5 to 5.6. So in conclusion, intervention radiologists play a vital role in overall diagnosis and management of bony metastasis in combination with a radiation oncologist, surgical oncologist, and medical oncologist. Pain score reduction with vertebroplasty, acetabuloplasty, and cementoplasty, improvement in SIN score for vertebral stabilization, and MSTS score for extremity or acetabuloplasty. And thank you.